All right, let's get started. So today we continue to talk about diabetes, and we're going to put everything that you've learned so far in this course in the context of diabetes in various tissues, including pancreatic beta cell, liver, skeletal muscle, and adipose tissue. And you've learned about GPCR, ion channel, and enzyme-coupled receptors, specifically receptor tyrosine kinase, and we're going to take a look at them to see their roles in diabetes. So we'll talk about the beta cell failure, the MODY genes, the insulin actions, and insulin receptor signaling, as well as the IRS, PI3 kinase, and AKT signaling pathways today. So we talked about ion channels specifically in lecture 4, and we learned that for calcium ions, they are more concentrated outside of the cell compared to inside of the cell. So there is a large electrochemical concentration gradient of calcium that is maintained across the plasma membrane, in this case, beta cell plasma membrane. So how is it achieved? It is through the membrane-associated calcium extruding systems to make sure that the calciums are excluded from the cytoplasm. And also there is an active calcium sequestration within the cell organelles, for example, the endoplasmic reticulum. So by doing it these two ways, the cytoplasmic concentration of calcium is maintained low. So what if we change this calcium concentration in the cytoplasm? What is the downstream effect in pancreatic beta cell? So the effect is actually insulin secretion. So how it is achieved is by an influx of the extracellular calcium into the cytoplasm of pancreatic beta cell through this channel, this ion channel, specifically calcium ion channel, called the voltage-dependent L-type calcium channels, or it's short as VDCC, that would open in response to beta cell depolarization. And this elevation in the cytoplasmic calcium is sufficient to initiate the insulin secretion from the pancreatic beta cell. If we prevent this calcium influx, either by remove the extracellular calcium or by pharmacological blockade of the VDCC channel that we just talked about, it would essentially prevent insulin secretion from the pancreatic beta cell. So we did talk about there is another source of calcium which is sequestered within the intracellular organelles such as ER. So glucose and other nutrients can also induce a calcium-dependent activation of the phospholipase C in the pancreatic beta cell. And we know that it will lead to the generation of IP3 and DAG. And both of them serve as secondary messenger in the pancreatic beta cell. And you've learned that the IP3 will lead to rapid mobilization of the intracellular calcium. However, the significance of the mobilization of this intracellular calcium in the secretory response to nutrient is uncertain, meaning it is not likely to have more than just a modulatory role for insulin secretion. So what this is telling us is that the major trigger of insulin secretion from the pancreatic beta cell is the influx of calcium, but this calcium is from the extracellular source rather than the intracellular source of calcium. Okay, so then let's talk about GPCR next. So we know you've learned about the GS and the GI. In addition to insulin secretion by nutrients, such as glucose and fatty acid, there's also regulation of insulin secretion by non-nutrients. So what are these? So beta cells actually express a wide range of receptors that's able to respond to peptide, glycoproteins, and neurotransmitters. And in human islets, the RNA profiling found 293 different types of GPCRs. However, these GPCRs, for a large amount of them, they actually share the same downstream cascade. So there's only a limited number of the effector systems downstream from these 293 different GPCR. So glucagon and GLP-1, which stands for glucagon-like peptide 1, they bind to the cell surface receptor that are coupled to adenylate cyclase, AC, through the heterotrimeric GTP binding protein, GS, or stimulatory G protein. So the adenylate cyclase hydrolyzes ATP to generate cyclic AMP. And you learn this, that the cyclic AMP is going to go ahead and activate pKa, as well as the exchange proteins activated by cyclic AMP. And they're called the epochs. So exchange proteins activated by cyclic AMP. For short, it's epochs. And both of these pathways, the pKa pathway and the epoch pathways, they both lead to insulin secretion. In addition, the norepinephrine and somatostatin, they can also bind to receptors that are coupled to adenylate cyclase through the inhibitory GTP binding protein GI, the inhibitory GPCR, and that will lead to a reduction of the activation of adenylate cyclase. And we know that as a result, we would have a lower concentration of intracellular cyclic AMP. And the end result of this is the inhibition of insulin secretion. So on the right, essentially, it is saying that GI and GS, they share the same downstream effector systems, and the outcome is to regulate insulin secretion from the pancreatic beta cell. Since we talked about the GS and the GI, we cannot forget about GQ. And in this case, the acetylcholine and cholecystokinin, they bind to the cell surface receptor that are coupled to phospholipase C, or PLC, through the heterotrimeric GQ. And you already learned this. The phospholipase C will go ahead and hydrolyze the phosphatidylinositol bisphosphate, PIP2 for short, to generate IP3, which is inositol 145 trisphosphate, and diacylglycerol, or DAG. And you know that the IP3 is going to mobilize the calcium from ER, endoplasmic reticulum, and DAG is going to activate PKC. So the end result is an enhancement of insulin secretion from the pancreatic beta cell. We talked about GLP-1. It stands for glucagon-like peptide 1. So what is its role in insulin secretion? We just mentioned that GLP-1 is going to activate GS and enhance insulin secretion. So where does the GLP-1 come from? So For the insulin secretion from the pancreatic beta cell, it is larger if we administer glucose orally than if we administer glucose through intravenous injection. Why is that? Because if we administer glucose orally, there is a response from the gastrointestinal tract, specifically to release gastrointestinal derived incretin hormones. So, for example, this GLP-1 is one of those incretin hormones. So it is implicated in augmenting insulin response after food intake. And GLP-1 has quite a short half-life, which is less than 2 minutes. As mentioned, it is secreted from the gastrointestinal tract, specifically the L cells. As you know, there are many different cell types in the gastrointestinal tract, and the GLP-1 is specifically secreted from the L cell. So GLP-1 interacts with the stimulatory GPCR on the beta cell to stimulate insulin secretion. And GLP-1 can be degraded by this protease called dipeptidyl protease 4, DPP4. So when people infuse this GLP-1 into type 2 diabetic patients before food intake, they observe that there is an improvement in insulin output. It also reduces the glucose level after a meal. So the GLP-1 analog liraglutide, so it's produced by Novo Nordisk under the brand name Victoza. This GLP-1 analog has an extended half-life of more than 12 hours. And it is because they incorporated fatty acid palmitate into this GLP-1 sequence. We learn from looking at the insulin analog, if we play around with the amino acid within the sequence of insulin or modify the insulin by adding other entities onto the insulin sequence, we can modulate its half-life. So here, another example is shown by the GLP-1. If we incorporate the fatty acid palmitate onto the GLP-1 sequence, then we can extend its half-life from less than 2 minutes to more than 12 hours. And it allows liraglutide to bind to the plasma albumin, therefore reduce exposure to DPP4, which degrades GLP-1. So another GLP-1 analog called sitagliptin, and it's made by Merck under the brand name of Januvia. It is a selective DPP4 inhibitor to prolong the half-life of endogenous GLP-1. So as I mentioned, since GLP-1 can be degraded by DPP4, if we inhibit DPP4, then we can extend the half-life of the GLP-1 that's made in our body. So in addition, the GLP-1 agonist also reduces the rate of major adverse cardiovascular events in the cardiovascular outcome clinical trials. So far so good, right? For GLP-1 receptor agonist and treating diabetes. So let's take a look at the currently available therapeutic strategy for treating type 2 diabetes. So first, we can improve peripheral tissue glucose sensitivity through some non-pharmaceutical approaches. For example, take steps to be more metabolic healthy, either through dieting or exercising or both. We can also enhance the peripheral tissue glucose utilization or clearance pharmacologically, such as through taking metformin or SGLT2 inhibitors. So what is SGLT2 and what is SGLT2 inhibitors? So SGLT2 is a transporter that's present on our kidney. So through evolution, we know that humans have become very efficient at storing nutrients. And think about it evolutionary. In the past, okay, we had to go hunt for food. The food are not so prevalent like we have this day. Therefore, whenever they are able to find food, the body has adapted a mechanism to very efficiently store every nutrient that we ingest. Of course, we know that nowadays it has become a problem for our generation. So the SGLT2 is a transporter on the kidney. Before we excrete anything through our urine, we're going to take a look at them again to see if there are any glucose molecules in that filtrate, and we're going to reabsorb it back to our body. So that's the job of the SGLT2 transporters on the kidney. Since we have now become a society where the food is plentiful, available to us 24/7, can we just inhibit this SGLT2 inhibitor and just excrete the glucose in the filtrate through urine? That way, we can decrease our circulating glucose level in the blood. So that's exactly what scientists thought, and what they did. They found inhibitors to inhibit SGLT2, therefore stopping the reabsorption of glucose from the filtrate. Therefore, the glucose can just be peed out, eliminated with urine. So that's another way for treating type 2 diabetes these days. And a third way, a third category would be to increase the circulating insulin. In the last part of the lecture, we talked about injecting insulin to decrease glucose level, and the modification to produce insulin analogs enabled us to either being able to reduce glucose level rapidly or through a prolonged period of time. Next, we can also increase insulin secretion from the pancreatic beta cell by inhibiting the KATP channels. We can also increase insulin secretion from the pancreatic beta cell with the GLP-1 RA or GLP-1 receptor agonists, such as liraglutide by Novo Nordisk. All right, so if we go on to the website of Novo Nordisk and we type in liraglutide, its brand name is Victoza, we'll find this message. It says the makers of Victoza have another non-insulin options for adults with type 2 diabetes. So let's take a look at what that would be. If you click on that, you will find this other drug named Ozempic. So in 2017, FDA approved this Ozempic, okay, which is called the semaglutide, as a once weekly GLP-1 RA, so glucagon-like peptide receptor agonist, in combination with dieting and exercising to improve the glycemic control in type 2 diabetic patients. So what's so good about this Ozempic treatment? In their clinical trials for the type 2 diabetic patients, the Ozempic treatment showed a meaningful reduction in their HbA1c. So we know what HbA1c is. It is the glycated hemoglobin, which serves as a proxy for a prolonged glucose level in the blood. So by using Ozempic as a medication, they found clinically there is a reduction in the HbA1c in the type 2 diabetic patient. And as a secondary endpoint in this clinical trials, they also observed that type 2 diabetic patients taking Ozempic showed a reduction in their body weight. That's interesting, right? And just like any drugs, all drugs have side effects. They all have adverse effects. So for Ozempic, patients reported to having nausea, vomiting, diarrhea, abdominal pain, and constipation. And the approval of Ozempic by FDA was based on the outcome of a global phase 3A clinical trial program that is comprised of 8 clinical trials involving more than 8,000 adults with type 2 diabetes. So that's quite impressive. And how Ozempic works to lower blood glucose level and HbA1c in adult with type 2 diabetes is through the following. So first, Ozempic helps the pancreatic beta cell to produce more insulin when the circulating glucose level is high. Second, it helps prevent liver from making and releasing too much sugar. So this is for non-biology major, right? So for you all biology major, you know that means it prevents hepatic gluconeogenesis after a meal. And third, it slows down food from leaving one's stomach. So how does that help? So let's say we eat, and if the food immediately goes into our intestine through our stomach, then you can imagine that suddenly there's going to be a large amount of nutrients, including glucose and fatty acid and proteins, absorbed from the intestine into our body, in our circulation, therefore in the blood, which gives the pancreatic beta cell, for example, a shorter amount of time to release insulin. So now if we can slow down the food leaving the stomach, therefore entering the gastrointestinal tract, we are kind of doing some traffic control to make sure that they don't all enter the circulation at the same time, therefore allow all the tissues a little bit more time to clear the glucose and the nutrient and the fatty acid that's entering our blood. Right? So that's what slowing down food leaving stomach can help in terms of clearing the nutrients, mainly the glucose in our blood. Okay, so we talked about for people with type 2 diabetes taking Ozempic, they have a secondary endpoint observing there is a weight reduction associated with it. That's interesting, right? So the scientists follow up on that phenotype. So in June 2021, FDA approved a Wegovy injection. So Wegovy is just another name, but the ingredient is the same as the Ozempic, which is semaglutide. All right, so in this case, this Wegovy injection is 2.4 mg once weekly as a treatment for chronic weight in adults with obesity or overweight, with at least one of the weight-related conditions, such as having high blood pressure, type 2 diabetes, or high cholesterol. And again, it's for use in addition to dieting and exercising. So Wegovy, just like Ozempic, works by mimicking GLP-1, and that can target area of the brain, therefore reduce appetite and food intake. And this medication dose is increased gradually to 2.4 mg through 16 to 20 weeks to reduce the gastrointestinal side effects. Okay, so even though it says it's semaglutide injection 2.4 mg, it is increased to 2.4 mg gradually through 16 to 20 week time period to reduce side effects. So what did they find? So in a large placebo-controlled trials, which takes 68 weeks, with adults without diabetes, okay, so they don't have diabetes, they showed an average body weight of 231 pounds, which is 105 kilograms, and an average BMI of 38 kilograms over square meter. Okay, they received Wegovy and lost an average of 12.4% of their initial body weight. That's a lot. 12.4% of one's body weight. Can you think for yourself? How many kilograms, how many pounds is that? And these people who take Wegovy lost it in 68 weeks. In addition, in the trial also spanning 68 weeks, adults with type 2 diabetes, and for those people, they have average body weight of 220 pounds, which is 100 kilograms, and an average BMI of 36 kilograms per square meter. After they receive Wegovy for 68 weeks, they lost 6.2% of their initial body weight. That's impressive. And like I said, Wegovy was given in combination with dieting and exercising. There's going to be side effects. And the common side effects associated with Wegovy, including nausea, diarrhea, vomiting, constipation, abdominal pain, headache, fatigue, indigestion, dizziness, abdominal distension, belching, hypoglycemia, low blood sugar, essentially, in people with type 2 diabetes and are taking Wegovy. So even though the weight loss is quite impressive, one would hope that the best scenario is not having to take these medication because of these side effects. All right, so we talked about what Novo Nordisk is doing for type 2 diabetes and weight management therapeutics. What about Eli Lilly? We know that it is also a company that invests heavily on research trying to find a cure for type 2 diabetes. So for Eli Lilly, they came up with a drug called Mounjaro. In May 2022, FDA approved Eli Lilly's Mounjaro, which is a tirzepatide injection. Okay, so tirzepatide. Yeah. As the first GIP and GLP-1 RA treatment. So GIP stands for glucose-dependent insulinotropic polypeptide. Along with dieting and exercising to improve glycemic control in type 2 diabetic patients. And the approval of Mounjaro was based on a phase 3 SURPASS clinical trial program, which included active comparators of injectable semaglutide, 1 mg, and insulin glargine. And we talked about what glargine is. Efficacy was evaluated for Mounjaro 5 mg, 10 mg, or 15 mg, used alone or in combination with commonly prescribed diabetes medication. And you know all of them, which are metformin, SGLT2 inhibitors, sulfonylureas, and insulin glargine. Participants in this SURPASS program, they're able to achieve an average HbA1c reduction between 1.8 to 2.1% for taking Mounjaro 5 mg. And if they take Mounjaro 10 or 15, they're able to reduce their average A1C by 1.7 to 2.4%. And while not indicated for weight loss, the mean change in body weight was a key secondary endpoint in all these trials. Why is that? Because they learned from Novo Nordisk's GLP-1 RA therapeutics, there is a benefit of body weight reduction. So of course, Eli Lilly will be very interested in finding out whether their Mounjaro also led to body weight reduction. And the answer is yes, the participants treated with Mounjaro lost between 12 pounds and 25 pounds on average. So like I said, every medication has its associated side effects. So for Mounjaro, side effects include nausea, diarrhea, decreased appetite, vomiting, constipation, indigestion, and stomach pain. So how does Mounjaro work? We mainly have learned how GLP-1 receptor agonists work. So when we add the GIP in combination with GLP-1 RA, what can we achieve? So first, if we take Mounjaro, the body will release insulin when blood glucose level is high. And also the body would remove excess sugar from the blood. And Mounjaro would stop the liver from making and releasing too much sugar. We know that is inhibition of hepatic gluconeogenesis after taking a meal. And as mentioned, there is a effect on appetite and food intake. So Mounjaro can reduce how much food is eaten. Last but not least, Mounjaro also slows down how quickly the food leaves our stomach. Okay, as we observe that there is a weight reduction, of course, Eli Lilly is not going to give up any chance of developing a new drug. And in this case, it's called Zepbound for weight management. So this Zepbound is the same ingredient as Mounjaro, it's tirzepatide, and it has different dosage. In November 2023, FDA approved Zepbound by Eli Lilly as a new weight loss drug that can help people lose up to 52 pounds in 16 months. And it's not cheap, right? Zepbound is not cheap. The list price in the US is about $1,000 per month. And Zepbound is the latest entrant into the field of powerful new drug that already includes the Novo Nordisk's Ozempic and Wegovy, and Eli Lilly's own Mounjaro. So Zepbound, again, belongs to a class of a drug called GLP-1 receptor agonist, and which reduce the food intake and appetite. Zepbound also include a second hormone, also an incretin, called GIP. So in phase 3 clinical trials, Zepbound led to a weight reduction of 22.5% body weight. It is about 52 pounds, and it surpassed all currently available weight loss medication on the market. Just think about it, 22.5% body weight. That's a lot, right? So you can think about your own body weight and what 22.5% that would be. And for a person to lose that much weight, that is quite impressive. And like I said, all medication has side effect. And for Zepbound, it has a risk for gastrointestinal issues, as well as nausea, diarrhea, vomiting, constipation, and stomach pain. And there's also additional health benefits for people who were involved in a 17-month clinical trial, and they also dieted and exercised. And those are, they're able to reduce their cholesterol level, reduce their blood pressure, and reduce their waist circumference. So as I mentioned, all these drugs, okay, Ozempic, Wegovy, Zepbound, and Mounjaro, they all were taken in combination with dieting and exercising, okay? And so let's talk a little bit about GIP. So GIP stands for glucose-dependent insulinotropic polypeptide. So both the GIP and GLP-1, they are naturally released from our gastrointestinal tract as incretin hormones, and they regulate blood glucose level. We know that GLP-1 binds to pancreatic beta cell through GS, stimulatory GPCR, to increase insulin secretion from the pancreatic beta cell. And for people without type 2 diabetes, the GIP has a greater effect on insulin release than GLP-1. And on the bottom left-hand side is a table that I made for you guys, summarize the 4 different drugs by 2 different companies, and the mechanism of action are listed. So on the right, let's take a look. So GIP and GLP-1 both increase insulin secretion, and they also have systemic effects on insulin sensitivity, meaning that they improve insulin sensitivity. And for stomach, we talked about slowing down the passing of the food from stomach into the gastrointestinal tract would help the body to clear the circulating blood glucose. And that's what GLP-1 can do. And for brain, GLP-1 reduces food intake. All right. Those are the currently available therapeutics for type 2 diabetes. So let's come back to talk a little bit more in depth about the beta cell failure in type 2 diabetes. So we know that when we changed our lifestyle from active to a sedentary one, or from eating normal portion to eating more or high fat containing food sources, insulin resistance would develop, right? And so as insulin resistance increases, initially the pancreatic beta cell would compensate by increasing the insulin production and synthesis. However, by doing that, the beta cell kind of entered this stress state, okay? And if the insulin resistance persists, it can lead to the decompensation of beta cell. And we won't have a normal glucose tolerance. That stage can be characterized as pre-diabetes. And this ongoing non-resolved condition of hyperglycemia and hyperlipidemia will lead to the beta cell glucolipotoxicity and eventually beta cell failure, okay? And by then, the functional beta cell mass would decline due to different mechanisms. And one of them is beta cell dedifferentiation. The other one is cell death. These paths would lead to type 2 diabetes. So what is beta cell dedifferentiation? So these are dysfunctional beta cells that are unable to maintain their maturity, therefore regress into a dedifferentiated state, like a progenitor state. Therefore, they're unable to properly secrete insulin in response to nutrient. And eventually, those dedifferentiated beta cells, they would undergo apoptosis. Okay, so we talked about type 1 diabetes and type 2 diabetes. There is another type of diabetes called maturity onset diabetes of the young, or short for MODY. So the MODY is characterized by an autosomal dominant inheritance of a gene that is mutated. And these genes are very important in insulin secretory pathway. So we learn in the pancreatic beta cell, all the genes that are involved leading to the insulin secretion. You can imagine if one of those genes has a mutation, the insulin secretion will be affected, correct? So let's take a look at some of them. Here is GCK. So we know that GCK stands for glucokinase, and glucokinase is the protein that once the glucose enters the pancreatic beta cell through GLUT2 transporter, it puts a phosphate on those glucose. Therefore, these glucose cannot leave the beta cell. And the glucokinase is also recognized as a glucose sensor. So you can imagine if the glucokinase gene is mutated, you will have some form of compromised insulin secretion, therefore some form of diabetes. And in this case, is MODY, specifically MODY 2. Okay, let's take a look at ABCC8. So that it has another name, which is SIR1, and you learned about SIR1. Another gene called KZNJ11, it has another name called KER6.2, and you learned about KER6.2 as well when we were talking about KATP channels. So you can imagine if there's a mutation in SIR1 or KER6.2, it will lead to ATP-sensitive potassium channel being dysfunctional. Therefore, we would have too much or too little insulin secreted, leading to MODY. Okay, so here is a graph summarizing what's happening in the pancreatic beta cell from low glucose, having low glucose, therefore no insulin secreted, to high glucose, therefore we need the insulin to be released from the pancreatic beta cell. So as mentioned, this is a summary. In the previous figure, we have more detailed steps. And this is a summary, meaning that it would be a good study guide and reminding you the things that are happening in the pancreatic beta cell when insulin is needed. One thing I want to mention is that unlike the glucose transporter in insulin target tissue, such as skeletal muscle and adipose tissue, the glucose transporter in pancreatic beta cell is not affected by insulin signaling, meaning their GLUT2, which is a glucose transporter, doesn't need to be mobilized. They are always on the pancreatic beta cell surface. And it is unlike the glucose transporter in insulin target tissues, such as skeletal muscle and adipose tissue, correct? In response to insulin, they will mobilize their GLUT4, glucose transporter 4, onto their plasma membrane to taking the glucose from circulating blood. All right, so as I mentioned, there are insulin targets on skeletal muscle and adipose tissue. And they need a receptor to respond to the insulin secreted by the pancreatic beta cell. And we know that it is a receptor tyrosine kinase from lecture 11. And here is an insulin receptor, and it is a transmembrane protein. It has the alpha subunit that is located entirely extracellularly, and it creates the insulin binding site. We also have the beta subunit, which is the transmembrane part of this receptor tyrosine kinase, and it separates the extracellular part from the intracellular tyrosine kinase. All right. So once the insulin binds to the alpha subunit, it's going to lead to an allosteric conformational change and the activation of the intracellular tyrosine kinase that's on the beta subunit by autophosphorylation, right? So we learned about this when we were talking about cancer. So autophosphorylation. And afterwards, the insulin receptor substrate called the IRS, so IRS, insulin receptor substrate, can bind to the phosphorylated tyrosine on this receptor. In the juxtamembrane domain of the beta subunit of the receptor. And once this IRS binds to the phosphotyrosine on the receptor, on the insulin receptor beta subunit, it's going to phosphorylate, the receptor tyrosine kinase is going to phosphorylate specific tyrosine motifs on the IRS. So it's shown here, okay? IRS binds to the phosphotyrosine, and this receptor tyrosine kinase is going to phosphorylate IRS. And the phosphorylated IRS can serve as a docking site for adapter protein with SRC, so Sark homology to SH2 domain, such as the regulatory subunit of the PI3 kinase. So the PI3 kinase stands for the phosphoinositide 3 kinase. All right, let's continue. So we just talked about the insulin receptor, okay? The receptor tyrosine kinase and the IRS, and then we ended up on the PI3 kinase. And the PI3 kinase is gonna go ahead and phosphorylate PIP2 or phosphatidylinositol 4,5-bisphosphate to generate PIP3 or phosphatidylinositol 3,4,5-trisphosphate. So, which is shown here. All right. And PIP3 is going to serve as the docking site for AKT and PDK1 to bind. So AKT here and PDK1 both would bind to PIP3. And PDK1 is going to phosphorylate the activation loop of AKT on the threonine 308, the amino acid number 308, which is a threonine. And AKT is also phosphorylated by this other complex called mTORC2 at another residue 473, which is a serine. So AKT is going to be phosphorylated at two sites by two different proteins. One is PDK1, phosphorylating threonine 308, and mTORC2 is going to phosphorylate serine 473. All right, what's next? So this is the same signaling pathway. It's just shown in a different graph. All right. So again, we have the insulin receptor, IRS, PI3 kinase, PIP2 to PIP3, and then we have the PDK1, the AKT. So we're going to talk about what's downstream of AKT. One thing I want to mention is that we've learned about pKa, right? We've learned about pKc. So AKT is pKb. B is a boy. So protein kinase B is another name for AKT. So what's downstream of AKT? So AKT is going to phosphorylate this Rab GTPase activating protein, AS160. Okay? And Rab is a class of small G protein found on GLUT4 storage vesicles. GSV is GLUT4 storage vesicles. And they have intrinsic GTPase activity. So if we inhibit AS160, would suppress the Rab GTPase activity. So Rab, it sounds familiar, right? Because we've learned about its family protein, which is the RAS. So Rab belongs to the RAS family of monomeric G protein that we learned about in lecture 11, slide 18. Okay, so Rab actually regulates the GLUT4 storage vesicles trafficking, and its activation is responsible for the translocation of fusion for these GLUT4 to be present on the cell surface, right? So that's essentially the pathway from insulin to mobilizing the GLUT4 transporter onto the cellular membrane. All right. So this is a 10-week long course. And Dr. Furlow and I are here to help you build a strong foundation for understanding cell signaling pathways. So in the future, when you see such a complicated signaling, you are not intimidated, and I'll show you why. Here we have the insulin receptors that we just talked about, and we have the IRS1 shown here. We have the PI3 kinase shown here. We have the PIP3. We have the PDK1. We have the AKT. And we also have the GLUT4 vesicle translocating to the plasma membrane. And on the other side, we have RAS, RAV, MEK, ERK. So by looking at this, you will say, hey, I know some of it. I'm not so intimidated because I can pick it apart and understanding it piece by piece, gene by gene, protein by protein, and pathway by pathway. All right, so let's talk a little bit more about diabetes mellitus. So in Indian, Chinese, Korean, and Japanese language, this diabetes mellitus is also called a sugar urine disease. And we already know the cause of diabetes mellitus is the deficiency in insulin regulation of glucose uptake by skeletal muscle and adipose tissue in combination with lack of negative control of glucose breakdown and from the hepatic gluconeogenesis. And we have type 1, which is the autoimmune disease. It is insulin dependent, meaning if one has type 1 diabetes, one will most likely need insulin injection. And the cause of type 1 is conventionally and traditionally thought because of the immune system attack, which lead to the destruction of the pancreatic beta cell in one's body. And the symptoms can often be overcome by insulin injection. And we know that insulin needs to be injected because if we eat insulin, it is a protein, it will be destroyed by the stomach acid. So before medically available insulin since 1923, we used to purify the insulin from pigs. But now we use recombinant insulin as a treatment. We also know that there is another type of diabetes, which is type 2. It is adult onset, and it has a strong familial association. And also, if one has central obesity, that is a risk factor for developing type 2 diabetes. And we know that it's characterized by a reduction in number of insulin receptors on the insulin-sensitive tissues and or other effects downstream from the insulin signaling pathway. And for that, one would develop insulin resistance. And hyperglycemia is quite damaging to blood vessels. And maybe you have heard some people would develop diabetes complication, includes retinopathy, neuropathy, nephropathy, and cardiomyopathy. And it can also lead to coronary artery disease, stroke, and diabetic vascular disease. And sometimes it can lead to amputation. So it's quite serious if left untreated. And we talked about the two arms of type 2 diabetes. One is insulin secretion from the pancreatic beta cell, right? So we need to have the signal, which is insulin. Second, we need a responder, which is the insulin receptor, and those insulin receptors are presented on insulin-sensitive tissue, including skeletal muscle, adipose tissue, and liver. So for insulin resistance in the skeletal muscle, people who have type 2 diabetes, they will show a reduction about 60%, okay? A 60% reduction in insulin-stimulated muscle glycogen synthesis. And it is one of the main abnormality underlying insulin resistance. And this impaired insulin-stimulated muscle glycogen synthesis is due to the defect in the signaling transduction pathway for glucose transport that we talked about. The GLUT4 has to present on the skeletal muscle cell membrane to be able to take in glucose in the circulation. So insulin resistance in the liver. So liver plays a major role, right? It is required to help us transition from fasted state to fed state and back to fasted state. So when we are fasted, the liver would perform gluconeogenesis to put out glucose to make sure that our blood glucose, circulating glucose, is maintained at a steady level. But when we are fed, the liver will turn off its gluconeogenic function because we just ate. We have glucose. Therefore, we don't need the liver to output more. Therefore, the liver needs to turn off its gluconeogenic action when we are fed. But this switch essentially is broken in type 2 diabetic patients. And it is characterized as the insulin resistant in the liver. And in insulin resistant individual with type 2 diabetes, they would show excessive postprandial, so after eating, hyperglycemia. And it's because they are unable to suppress glucose production. And also they are unable to accumulate the glucose in the liver after eating a meal compared to healthy people. And insulin-mediated hepatic glycogen synthesis correlates inversely with ectopic lipid content in the liver in people either with or without type 2 diabetes. So there is a close link between hepatic lipid content and hepatic insulin resistance. Okay, so that would be all for diabetes, and this is the learning objectives for lecture 4. All right, see you next time.